Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on managing suboptimal CD4 cell count increases despite suppressive ART, featuring Dr. William Short from the University of Pennsylvania in Philadelphia. He'll take us through a case study and the data supporting guideline recommendations on whether to intensify therapy, switch ART, or add an agent such as interleukin-2. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Short.
Thank you for joining our key decisions in HIV today. Today's topic is patients with suboptimal CD4 cell count increase despite suppressive antiretroviral therapy. My name is William Short. I'm an associate professor of medicine at the University of Pennsylvania in Philadelphia. Let's start a discussion with a case study. So 46-year-old male diagnosed with HIV 3 years ago presents for a follow-up visit to your office. He is currently on a regimen of dolutegravir and again fixed-dose FTC TAF. His CD4 nadir at diagnosis was 90 cells per millimeter cubed, and he has just had recent lab work done. As you can see here, some of the characteristics. His current CD4 count is 100 cells per millimeter cubed. His virus load is fully suppressed. He had a pre-therapy genotype done, which was wild type. He's immune to hepatitis B. He's non-reactive to hepatitis C and immune to hepatitis A. His serum creatinine is 0.9. You can see his transaminases there within the normal range for a male. CBC is normal. His total cholesterol is 180, HDL 30. His BMI is 28. And his hemoglobin A1C is 5.4. So let's talk about poor CD4 cell count recovery. So most individuals on antiretroviral therapy will have a CD4 cell count increase for at least a decade. The most rapid response you're going to see is in the first 3 months of being on suppressive antiretroviral therapy, followed by a gradual increase over time. If antiretroviral-mediated viral suppression is maintained, most individuals will eventually recover their CD4 count in the normal range, which is defined as greater than 500 cells per millimeter cubed. About 15 to 20% of individuals who initiate ART at a lower CD4 count will eventually plateau at a low count and have a very poor CD4 recovery, and therefore their CD4 counts may remain less than 200 despite having a suppressed viral load for over 2 years. Earliest initiation of ART really provides the best opportunity for maximal CD4 recovery. So let's look at CD4 recovery on antiretroviral study. This was a longitudinal cohort study conducted between 1996 and 2004 on antiretroviral naive patients, and they were followed over time, and the outcome was to see what probability of patients achieved a CD4 count greater than or equal to 800. And what you can see here is that it was feasible within 7 years in groups who had started with a CD4 count greater than 350. And also what you see here is the lower you start, the lower your rise was over time. So it's really important. The take-home message from here is that starting antiretroviral earlier when your CD4 count's high may be most beneficial. Obviously, for patients who present with lower CD4 counts, that may not be optimum or a choice for them. So what are the consequences of having a low CD4 count despite having viral suppression? Well, we know from numerous studies there is an increased risk of morbidity and mortality with persistent low CD4 counts. In patients with CD4 counts less than 200, despite having 3 years of ART, there was a 2.6-fold greater risk of mortality than those with higher CD4 counts. There was also an increased risk of non-AIDS mortality and morbidity, and these come in the form of cardiovascular disease, osteoporosis and fractures, liver disease, and infection-related cancers. One of the things that you should do always is evaluate for reversible or modifiable causes of CD4 cell lymphopenia, and that would be certain drugs that may do it. Does the patient have untreated hepatitis C infection, or do they have an underlying malignancy? So some other strategies that have been looked at for CD4 recovery are using antiretrovirals to intensify the regimen. Here's two such studies. One is using raltegravir, which is an integrase inhibitor, and the other one is using maraviroc, which is a CCR5 co-receptor antagonist. In the first study, raltegravir or placebo was added to patients on suppressive ART. They had to have an HIV viral load less than 50 copies for greater than 1 year and have a CD4 count less than 350 cells per millimeter cube. And in that study, after 24 weeks of intensification, peripheral CD4 T cell increased by 19 cells in the raltegravir group and 36 cells in the placebo group, with a p-value that is not statistically significant. And similar results we saw in the group that received Maraviroc or placebo that was added to a suppressive regimen. Again, very similar design. Patient had to have a virus load less than 50 copies here for 6 months, CD4 count less than 350 for 2 years on ART, or less than 200 for 1 year on ART. And what you can see from the graph there, whether they got placebo or Maraviroc, there was really no change or different in their CD4 cell count. So another strategy used to improve CD4 cell was switching antiretrovirals. We're going to talk about the SPIRAL study. And here, these were patients with HIV RNA less than 50 copies for at least 6 months, and they were on a boosted protease inhibitor regimen. They were randomized to continue current antiretrovirals or switch to raltegravir. Their median CD4 count at baseline was 516. And note that this is different than what we're talking about, where patients had lower CD4 count, but we actually want to talk about what happens when you switch. Is there an increase in your CD4 cells? So this was not the primary endpoint of the study, but the secondary endpoint showed that there was no significant differences between the treatment groups in CD4 cell count change from baseline to 48 weeks. And you can see the numbers in there when you compared the raltegravir group versus the boosted protease inhibitor group. So despite having to switch off of a boosted PI to a raltegravir-based regimen, where the thought was maybe you would get a CD4 cell increase, that was not observed in this trial. Another trial that's a little older but has been studied is, what about if we use interleukin-2 to increase CD4 count? And while this is an older study, it really does hone into that point and answer the question. There were 2 studies done that compared using interleukin-2 plus antiretrovirals or antiretrovirals alone. The primary endpoint of the study was opportunistic infection or death. And the difference between these 2 studies was what was the CD4 count. One had a CD4 count between 50 and 229, and the second study had a CD4 count greater than 300. And what you can see here in the graph, as well as the summaries at the bottom, are that yes, given interleukin-2 with ART did cause an increase in your CD4 T cell count. However, when you look in bold, what you saw is the primary endpoint, which was opportunistic infection or death. There really was no difference between the 2 groups, as you can see there from the hazard ratios that are 0.94 and 0.91 respectively, with confidence intervals that actually include 1. So again, here showing proof that interleukin-2 did really not work as a good mechanism of CD4 recovery strategy. So when you turn to the guidelines actually give some clear recommendations on what to do when you see patients who have low CD4 counts. So number 1 is that adding antiretroviral agents to a suppressive regimen, which is known as ART intensification, does not improve CD4 recovery or reduce immune activation, and is therefore not recommended. In addition, in individuals with viral suppression, switching drug classes does not consistently improve CD4 cell recovery or reduce all relevant markers of immune activation, and again, is therefore not recommended. The third point is that interleukin-2, as we just showed you, is not recommended to increase CD4 counts and or decrease immune activation because, again, clinical trial data has not demonstrated a clinical benefit. So in summary for this key decisions in HIV, the take-home points are as follows. Persistently low CD4 T cell counts and immune activation are each associated with increased age-related and non-age-related morbidity and mortality among individuals who have achieved antiretroviral-mediated viral suppression. Patients should be evaluated for modifiable causes of CD4 T cell lymphopenia. In addition, efforts to decrease morbidity and mortality during antiretroviral-mediated viral suppression should really focus on addressing modifiable risk factors for chronic disease, such as smoking, healthy diet, and treatment of hypertension and hyperlipidemia. Adding or switching antiretrovirals is not recommended, nor is the use of interleukin-2 recommended. And other interventions to increase CD4 cell counts are not recommended outside of a clinical trial. So in order to gain more information, please go online for more clinical care option activities on key decisions in HIV care. There are medical minutes and podcasts with expert faculty. There's clinical thought commentaries from physician and patients. There's also patient education sheets to print and share. And the website is listed there. It's clinicaloptions.com/HIV. Thank you.
Thank you to Dr. Short, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.